And again, we have two clinicians with different perspectives, and we have two advocates on this panel. I'd like to introduce our first speaker from the clinician side, and that will be Professor Stephen Opat. And Stephen Opat is a leading international clinical researcher in CLL and lymphoma, ranked in the top 1% of published authors worldwide in both CLL and lymphoma participation. And he serves on the Immunodeficiency Task Force, the CLLIC task force that we spoke about. He's a collaborator in 20 pivotal international studies that have defined the therapeutic landscape of CLL. And by the way, you'll find all of these bios and the longer versions, the versions they all deserve to have read here in front of you all online with the conference material. So Professor Opat, if you could.
Thanks, Peter, and I'd like to also thank Nick and Brian for giving me the opportunity to present to you today. So I have got a lot of slides, so I apologise. I'm hoping this works. So first of all, we're talking about what is a high-income economy, and here is a map of the world, and the blue areas are high-income economies, which is defined by the World Bank as having a gross national income of more than $14,000 US or in 2024. And you can see here, I'm from Australia over there, and right next door to us is New Zealand in blue. And why I've put this map up here is because there are vastly different situations in Australia and New Zealand. We have access to all the drugs. We've had access to zanubrutinib on clinical trials since 2014. We've had access to sonrotoclax on clinical trials since 2019. We've got 73 studies open in CLL in Australia. So we're very lucky. We're really fortunate, but our...
Just for the sake of understanding, that's all right.
Our colleagues in New Zealand still have FCR and BR, and they can use ibrutinib and venetoclax in patients who have 17p. So we are trying to work hard with our neighbours to the east to see if we can have the same access that we have in Australia. Now, the next slide is the relative survival, and let me. There's two lines there. The top line is the 5-year relative survival. So this is the proportion of patients who are alive compared to people without CLL. And you can see that in the top line, which is 2014 to 2018, it's 92%. But that was before we had access to any novel drugs. That's just with rituximab. So I think so things are getting better. And I think with another 5 years, when we look at the next slice, the relative survival of CLL patients we anticipate will be very similar to the normal population. But we do have challenges. We like we've heard, we have problems with Richter's cancer, we have problems with second cancers, particularly in Australia, melanoma, and I'll show some data a bit later. And we've also got big problems with infections, and infections can account for up to 60% of deaths of patients in CLL, but it really depends how you count it, because if someone gets treatment, they get an infection, is that disease related, is that treatment related? You know, it's always hard to know. And so this is from a developed country. You can see the minority of patients now will die from CLL progression. That's in the blue area. And there's a number of other things, such as other cancers or infections or heart disease or stroke. Many of these are preventable. And one of the problems we have with our patients is that when they've got diagnosis of CLL, they may no longer attend their primary care physician. They're actually treating their hematologist or their specialist, the primary care clinician, and a lot of these things get lost. I know, and my colleagues, we very rarely check the patient's blood pressure, even if they're on BTK inhibitors. So we really need to do better in these preventable areas of infection, vascular disease, and cancers. And so I won't go into this because it's a bit, there are a number of factors when we're trying to work out what treatment is best for the patient. We have access to almost everything you can think of and many trials. And so one of the main factors is what does the patient want? And you can see here, the decision really is when we're treating a patient, do we want to give them time-limited therapy or do we want to give them continuous therapy? This is the same question when I started treating CLL 25 years ago. The only difference was we were talking about a drug called chlorambucil. Do you give it continuously to progression or do you give it in limited blocks? And so there's advantages to both. I think amongst clinicians, there's some sort of favouring the time-limited approach because it allows long treatment-free periods, immune restoration, and it may be cheaper to treat someone for a shorter period of time. But the downside is the more drugs, the more side effects, and one of the main problems of continuous treatment as well as shackling the immune system is a risk of developing drug resistance. So I put this up. This has got all the major phase 3 trials in CLL with many drugs. And this is really just to say, it doesn't really matter. We have so many good options. Everyone's got their favourite treatment. But whether you go for time-limited or continuous therapy, these curves are a proportion of patients who are disease is under control after 4 years of treatment. And they're all good. So we have very many good options. The other thing to say, this is important because what it's showing, this is from the CLL14 study, and this is talking about acquiring resistance mutations. And what this is showing, you know, in the green is the number of resistance mutations in people getting venetoclax, and in the blue is the number of resistance mutations in people who are getting chemotherapy with chlorambucil, obinutuzumab. And so what we're saying is that how you treat people matters, because if you give chemotherapy, you will lead to resistance mutations, which then will make it harder to treat at a later date. This is also from another study, the Captivate study of ibrutinib plus venetoclax in Australia. And what this shows is that when you stop treatment, when you're off all drugs, the immune system recovers. So the panel nearest me is the B cells, and there's the regulatory T cells, which are suppressing the immune system, fall to a normal range in the middle one, and the dendritic cells, which are also important governors of the immune response, all respond. So this is some of the reason, and there's many trials I could show that treating for a fixed period will allow people to recover immunity. As we've heard already, we've talked about second cancers, and again, there is increased risk of many second cancers. This is from a Netherlands cancer registry. They've got 3 times the risk of melanoma. There's also been discovered some susceptibility genes that make patients susceptible to both CLL and melanoma, which brings the whole area of genetics into it. Things like AML related to chemotherapy. So many of these are preventable. In Australia, we've got funded CT chest scan screening for smokers. So I'm now getting my CLL patients to get a CT of the chest, because you can see here they've got increased risks of lung cancer. This is an Australian study on melanoma, and we discovered in people over the age of 80 on BTK inhibitors, their risk of melanoma was about half the risk of CLL progression. So if 10% of patients had CLL progression in a year, 5% of patients got a new melanoma in a year. So melanoma in Australia with all the sun is a big problem. There are other things which people don't even consider, such as osteoporosis. But whether it's from being ill with the disease or a direct effect of the disease, there's a risk of osteoporosis. I think I don't have to tell anyone in the room about the psychological impact. I feel like a fraud talking about it to you. But, you know, whether it's loss of independence, the nature of an incurable malignancy, you know, how stressful is watchful waiting. And most of my colleagues don't really appreciate how you know, telling someone they've got cancer, but we're not going to do anything about it, how stressful that is. As well as the fact, you know, worrying about catching an infection from their grandchildren that could be life-shortening. So I talk about CLL survivorship. Survivorship might not be the best word, but it's looking at things other than the disease. And there's a number of other domains, you know, not just preventing heart disease and cancers, but looking at the emotional and psychological impact, looking at bone disease, social factors, income, financial frailty. So I think now, because we've got all good treatments and because the outcomes are approaching that of the general population, we now have to focus on all these other aspects, which I think are important to our patients. So in Australia and probably in the States, most patients are expected to die from causes that are indirectly or unrelated to the CLL. The lifelong risk of physical and psychosocial morbidity, they experience lifelong risks of morbidity due to the disease. And we've also got a problem in healthcare with the increasing number of CLL survivors. We're trying to find doctors for them. And we really need to focus on the well-being of patients beyond their cancer diagnosis. And the optimal approach includes the empowerment of all the patients to take ownership of their survivorship care, long-term health and well-being. Thanks.
Well, I know we gave you a tall order to to fit all that in a short period of time, Dr. Opat, or Professor Opat, but it's very good, thank you. And I'd like to turn it over to Professor Dr. Karanfilski again.
Do the presentation from this microphone instead, because then you wouldn't lose my voice when I turn towards the panel. So some of the points are the same, but some are like different and more directed. So we can switch again to the next slide, which is the only slide that I have for this presentation as well. And this is how we manage a patient with CLL. So I told you the short version of the story, but this is somebody that doesn't have the time to discuss with the patients. My first surprise when I switched from public sector to private sector is that patients came to me with a diagnosis, with an examination, with the results, and with an opinion what they should do in the public sector. Said, why did you come to me? Said, nobody had the time to explain it to me. They just said, read the report, everything is in there. That's something that I have never agreed with. My bottom point is always remaining, talk to the patient. That's the one thing that consult means. You talk to the patient. So, still the most difficult challenge in my career has been to deliver the diagnosis of leukemia to a patient and tell him you don't need treatment. Patient probably goes home and said, I've been to a crazy doctor. He says, I have leukemia and they're not going to treat me. This is true for 60 to 70% of the patients with CLL. And it doesn't diminish, maybe occasionally more than in the general population, the quality of life, but not the survival. So this is still one thing that patients need to understand. Patterns of treatment are switching. Chemo is almost abandoned in the world of CLL. We're switching to signaling modifications, to antagonists of signals, to blocking of signals, to immunotherapy, so it's quite different. And all over the field of hematology is like that. It's very efficient in some diseases and not as efficient in others. So I told you that it's mostly the doctors who decide on the most efficient or useful treatment for the patient. But there can be place for discussion and for, let's say, modifications. It's a fine line of balance how to not over-treat the patient, but not to diminish his or her risk of shortening the survival. So there is this margin that you can discuss within. I should be seen as a representative of orthodox medicine. I mean, we are not dealing with kids' diseases. We're dealing with malignant diseases. My first goal is always save the life of the patient. We can discuss how to not diminish the other points and stages in life. But this is the primary goal for me. So this is why balancing has a thin margin, but it is still possible. My primary concern, I already told you. And then when we're discussing quality of life, patients should understand that it's not only the disease that affects the quality of life. There are consequences of the disease that will diminish certain possibilities that those patients did have before. But then there is something that is caused by the age of the patients. Remember, this is mostly a disease that arises in patients with advanced age. Then there is something that, due to the age and possibly other comorbidities, has already diminished the capacity of the patient. Another one, like CLL, should add to that, but it's not always to the disease. It's not always the CLL that makes a fuss about the quality of life. It's something with it. So you can correct one aspect, but you cannot, not yet, correct age. That doesn't go backwards. The one that we're all here about is problems like adverse effects of treatment. We're diminishing these because chemotherapy had a lot of those. Biological therapy has different, but not as severe or as frequent as chemo. Chemo usually always gave fall in the parameters of the blood counts and everything. Biological therapies and targeted therapies don't always do that. In some patients, yes, in some patients, no. The last 3 points are the same. I've already talked about that. The point is, I have perceived my profession as magicians lately, and then I found out that that is not a correct representation, because magic is usually based on illusions. You know they're tricking you, but it looks fine. Chronic, not chronic, but hairy cell leukemia, acute promyelocytic leukemia, chronic myeloid leukemia, to a very large extent, Hodgkin's disease, are now treatable malignancies. This is a sentence I could not even imagine I will say any time in my career as a hematologist. So now, what I think hematologist represents is not a magician. It rather resembles a role of Denzel Washington, and that is the equalizer, helping us remain in the balance of life and death. Thank you.
Well, that's very good. And I'm going to ask you, I apologize, so I'm going to ask you to pull your chairs this way so you're in front of the screen now, because that's how our friends in the AV will be able to pick you up. So We'll get used to this over time. Yeah. Thank you. Well, you all deserve those heavy leather chairs. This is why we don't do it. So I have one question for our advocates here. We have Rita Christensen. Hi, Rita. I didn't see you come in. There you are.
I'm here.
And
I was in the corner.
yeah, oh, yes. Is your organization, is it Lille or Lyle?
Lyle, because it's a abbreviation of lymphoma and leukemia.
Very good, Lulia. I'll have to try to remember that.
Lyle.
And we have Cindy. See, I got you, Cindy. And Cindy Yang, and you're from Max Smiles in Thailand, right?
Yes.
So I have one question for the two of you, which fits nicely with what our professors have said, is we talk a lot as advocates about quality of life compared to quantity of life. And in many cases, you know, we've done a very good job, or the clinicians and research done a very good job extending life. But I know advocates move towards quality of that life as well. So I want to ask you both how you approach that with a patient, that question between the balance of quantity and quality of life. Go ahead.
First of all, you have to listen to the patients. What are their problems? Because it's very individual. Some people are telling us they are fine and treatments are well and they have a good connection with the doctors. But however, there are also patients who are not having this good connection or don't know how to communicate with the doctors and how to get this what it's called, that you are heard from the doctor. And they think that if somebody is listening, that's the first step to get a better quality of life. And if you have the information about your diseases, it's better. And you are meeting with other people who has the same disease. They are exchanging experiences also.
Okay, very good. Cindy?
Okay, let me clarify the word quality of life. For me, quality of life means mental health support, access to nutrition, to good nutrition, the ability to move, then also to smile and to be loved with your community, right? Agree? That's one point. And then now I think we are discussing about cure and care, right? How do we cure the disease, that part of the medicine, but how do we care? That's how we manage with the quality of life. As myself from medium and low income country, they are fighting mostly on the two issues. The one is the battles on against the cancer, definitely everybody. And then the other one is the daily struggle. Yeah, how do you, with the side effects and the financial challenges and even with the emotional stress. How we do is, as an advocate, we encourage, we set up the community with all the patients, and in Asian culture, we speak less. Okay, I speak more now. And the patient is not there to talk to the doctor. So we set up the community. When we see each other, what we do is we try to encourage all the patients. First, we give them information. We make things in simple language. What you are having with yourself, how you are treated, and what kind of medicine you will be taking, and what side effect you will be facing. We make these things simple in easy language. Next, we make them understand first. Then next, we ask them that you are there. You got right to ask. Raise up, that's yourself. Okay. I have patients that come to me with the stress, and they go back. Next time when they go see doctor, they are more courage to ask, then they feel better. Yeah. So I make this message simple today. I believe that cure is important, but care is also as much as important. Extending life is a gift, but helping people to live well and with a smile, it's a true success of modern medicine.
Thank you.
Thank you.
Can I add 2 points to that? I have always thought that it's the doctor's responsibility to adapt to the communication level with the patient. The doctor should be able to manage the language from technical to normal everyday communication so that it is understandable for the patient. When I talk to the patient, it's not of how I make a legend of myself. It's how much the patient understands what I'm saying. That's my satisfaction. So the doctor should be able to adapt more than the patient rise to the technical or professional level. That's not expected. The second point I want to make, I am very happy when survivorship analysis come to the professional stand. That means for me, and that comes from an analysis I did in Hodgkin's disease. Until 2000, I found only like 30 or 40 articles that were talking about secondary effects in Hodgkin's disease. From 2000, I find 3,000, which in my language means we've managed the disease, now we're looking at the consequences. And for me, this is success.
I think that's all the responsible of I think it's from the two sections. The doctor, it's not easy for you to speak in simple language. And for patient, it's not easy how to begin asking. So that's where the role of the advocate comes in. Yeah, and pull the gap closer and closer. And the best is both sides could understand. Even if not, and that's where advocate's role is.
The doctor needs to learn this.
That's why it's very important to have a patient advocate or a patient organization, because we are talking with the patients in lay language, and we can explain the patients what is it about if they don't understand from the doctor, and we are also collaborating with the doctors to explain them that patients need that lay language so they can understand. First of all, if you get the diagnosis CLL, what is that? And that's a big issue for the patients, and you have to learn a lot about your disease.
I just wanted to call out the CLL Advocates Network task force, because I think a lot of the things we mentioned can actually be done very well in low-income countries. You know, things like monitoring blood pressure, things like immunization against infection, you know, evaluating mental or psychological distress. A lot of those things aren't particularly expensive. So I'm hoping that with the task force work that's currently in place, that we get some form of communication that can be universally applied across different income countries.
One question, time for questions. Is there a question out there? I see people scratching their face. Okay.
Christensen from MPN Thailand. Okay. Actually, I have one question from the patient. Okay. He told me that when he came to visit the doctor after each appointment, okay, he didn't dare to discuss with the doctor, but his situation that he got the remission, okay, he got the remission from the disease, like CLL, for example, okay, but the doctor always talk about the outcome of survival, but don't talking about too much about the quality of life and side effect. How can we recommend or how can we stimulate both doctor or the patient in order to give more attention to the quality of life and side effect?
My perspective, I think I told you that I do talk to the patients as much as they need in all aspects that they ask me about. I simply don't look at the clock about that. But, you know, remission in CLL is something that is still time limited. You're almost certain that it will relapse at some point of time. So it's not the curve type that I like to see. I like to see curves with plateaus. That means that the patients under the plateau will never go into disease again. But, and I spoke that quality of life is not affected only by disease, only by the hematological disease. So I'm probably not going to be able to help your patient if he has like emphysema, or help him in that sense that he would overcome that problem. But other than that, I could probably distinguish between the things that affect him from the standpoint of CLL. And that is something that everybody here was talking about: prevention of infections, treatment, more than standard treatment. If an infection occurs, secondary cancers are not the top of the concern in CLL because they're mostly skin cancers, but they should be attended with attention, and this requires the level of knowledge from the physician, from the hematologist. But talking to patients is the basic message I need to convey. As the advocates are always talking to the patients, we should be able to do that as well, and talking to the patient advocates as well.
Yeah, it's very difficult to help patients with side effects, but we are talking about it, and you have to confront your doctor, hematologist, that you have these side effects, but the doctors were not taking it seriously. Until now, we have in Denmark established side effect clinics where the patients can come and get some help, psychological or other help, how to deal with it. And that, I think, is a very good thing. We have worked on that in 1 year with the politicians to establish this in Cancer Plan 5 in Denmark. And because it's also very difficult for the doctors to manage side effects. So I think it's very useful to talk with the pharma how to improve the treatments in the future.
I think quality of life is part of feeling insecure. Yeah, so if you could able to explain to the patient, either by the advocates or from patient, from doctors, if we could make the patient understand feeling less insecure, and that could increase the feeling of better living, increase the quality of life.
And you are in a community where you meet others who has the same issues. So that's also a relief. I'm not alone in the world.
Very good. I'd like to thank this panel, if I could. Thank you very much for your time and your thoughts.
Thank you.